All right. Good afternoon. Hopefully everyone can hear me. We are going to start this next talk. This is a sponsored talk. Alexion, now AstraZeneca, has sponsored this talk on Andexxa. I am Niels Martin. I am a surgeon at the University of Pennsylvania, and I am going to take you through the next little while. This is a commercial talk on behalf of Alexion Pharmaceutical. This is their slide set, but I'm going to give you this talk as opposed to a rep from the company so that I can give you my personal interpretation of the data that I'm going to present to you. Hopefully you will find this helpful and informational, and I am more than happy to answer questions either as we go along or at the end of this talk. That being said, I do want to thank Alexion for the privilege of being able to speak not only on behalf of them, but before this audience. I wish I was there in person. I certainly wish I was wearing a Hawaiian shirt right now, but unfortunately I am in Pennsylvania. So the goal, sorry, I'm just waiting for the slide to advance. The goal of the next little while is to really talk about the burden of life-threatening bleeds that happen on 10A inhibitors, such as apixaban, rivaroxaban, and just how often that happens across the country and how often it comes into clinical play that we have to deal with patients on these drugs who are dealing with a life-threatening emergency. Andexxa is a specific reversal agent to 10A inhibitors, and I'm going to talk a little bit about its mechanism of action and then take you through the indications for use, some of the important safety information, and then briefly go through some of the studies that have gotten us to where we are today with this technology so that we can appropriately incorporate it into our practices in a reasonable fashion. So the first part of this is really talk about the number of patients who we see on having life-threatening bleeds on 10A inhibitors. I think we all recognize that the use of 10A inhibitors has been increasing over the last several years across the United States and actually across the world. And this is because 10A inhibitors actually act much more conformationally than the previous gold standard, which was warfarin. Warfarin, as you know, if you vary your diet or have different things happening in your physiology, your INR levels can absolutely get abnormal. Whereas, in theory, the 10A inhibitors are a much more routinely acting drug. They don't need levels that are followed. And therefore, they have been endorsed by a multitude of the organizations that deal with patients who need anticoagulation. And so the use has gone up across the country. Now, this is good because this, in theory, is a better actor than warfarin, which does have a higher incidence of life-threatening bleeding. However, DOACs themselves still have some inherent risk. And that inherent risk can equate to over 400 patients a day presenting to hospitals across the United States and up to 70 deaths each day due to life-threatening bleeding on 10A inhibitors. And so this is really the population that we are going to focus on as we talk about Andexxa. If we can change these outcomes, I think we can really have a big impact in terms of this population. And so that's kind of the perspective of what we're going to go through today as we talk. As you can imagine, the types of life-threatening bleeds can happen all over the body. They can happen as intracranial hemorrhages that are either medical or traumatic. You can have bleeding at any critical site around the body, like the pericardium or intraocular bleeding. Of course, major trauma, blunt trauma, solid organ injuries are areas that can also cause a lot of bleeding. And then bleeding that can result in significant hemodynamic instability, such as GI bleeds, are also places in which 10A inhibitors can cause significant problems, and where reversal with a specific reversal agent may be more advantageous. And just to put a little bit of it in perspective, this is some data from the trials that brought the two most common 10A inhibitors to market. So this was the Aristotle and Rocket AF trials that were published about 10 years ago when 10A inhibitors really started coming about. And what you can see here is this is data on those patients during those trials who had an intracranial bleed. And what you can see here is that the 30-day mortality was quite profound in this cohort. It was nearly 50%. And I'm going to kind of keep it as not spoil it for you and keep it as something to look forward to later in the talk here. But I will say that when this population has been looked at with the advent of Andexxa, that these mortality rates have been significantly improved. And so keep these numbers in mind, a nearly 50% mortality rate with intracranial hemorrhages. So just as a matter of understanding scientifically, when we look at the activity of 10A inhibitors, that is, and the accepted gold standard across the industry is to look at anti-factor 10A activity. And that is the agreed upon enzymatic measure of 10A, of factor 10A. And so we will be using anti-10A activity throughout this talk and really throughout the literature as a means of measuring the effectiveness of 10A inhibitors. The other important thing to note as we talk about this topic is the fact that prior to having a specific reversal agent, many of us used PCCs in the setting of major life-threatening bleed in a 10A inhibitor. Unfortunately, PCCs don't really have a great mechanistic rationale to work, and many of us used it because we were looking for something to use. And in fact, PCCs are not even FDA approved for the reversal of 10A inhibition. And I will show you a little bit of science here that will hopefully support that notion. This won't get overly deep, but this is the coagulation cascade. As you may recall, it has an intrinsic and extrinsic pathway. They meet at factor 10, which then becomes activated factor 10, which then allows for the creation of thrombin and fibrin and therefore your clot formation. When you give someone warfarin, you inhibit the factor, the vitamin K dependent factors, which you can see here highlighted. All of those factors, interestingly, are upstream of factor 10A. And so as you inhibit those factors with warfarin, when you give PCC, you're replacing the factors that were inhibited by warfarin. And that's why PCC works so great for warfarin or Coumadin reversal, is you're replacing the factors that have been inhibited and you allow for clot formation. However, 10A inhibitors, by name, affect factor 10A. And so you can give all the factor you want upstream, but if factor 10A is still blocked, you are not going to generate clot. And that is why there is not a great mechanistic rationale for the use of PCC in 10A inhibition. And so really, you need to find a way to remove the 10A inhibition specifically. And we're going to go into that in a second. This is one study that compared PCCs to saline in the reversal of anticoagulated patients. And so this was actually a healthy volunteer study of folks who allowed themselves to be anticoagulated on rivaroxaban, and then they were randomized to receive PCC or saline. And as you can see, the degradation curves here really both followed the half-life degradation of the 10A inhibitor, and there was really no difference between the curves. So unfortunately, in this study, and in most, PCCs are not very effective in the reversal of 10A inhibition. And that's where Andexxa comes in, because Andexxa is a specific reversal agent for 10A inhibitors. It was tested against and therefore is improved for the use against rivaroxaban and apixaban. But as we talk about the mechanism, you'll see it should work for most 10A inhibitors. And it has been tested and therefore FDA approved for reversal in the setting of major life-threatening bleeding. Now, there are a couple of different things to know here in the package insert. The first is the black box warnings. And the black box warnings really surround the concept that you're reversing anticoagulation in patients who have an indication to be anticoagulated. And of course, yes, in the moment they are bleeding, but when they're no longer bleeding, whatever that underlying indication was is now allowed to become clinically relevant. And so that might be just a fib or a low CHAD score fib, but it could be a hypercoagulable state. It could be a patient who just had a DVT or a PE. And so we really, I think as clinicians, need to be cognizant of the fact that these patients are at higher risk of thromboembolic and ischemic events. And we should think about when to re-anticoagulate them. And we're going to talk more about that concept in a few slides. But the thromboembolic and ischemic risk in this patient population is significant. And I'll show you some of those numbers again when we get to the data. The other important things to know is that Andexxa has a relatively short half-life. And once the infusion, a little bit of a fast forward, but Andexxa is given as a bolus followed by an infusion. Once that infusion is stopped, the Andexxa leaves or clears the patient pretty quickly, and you can have a slight bump back up in the patient's level of 10A inhibition. However, I will show you some data that shows that thrombin generation is not affected in that period, and that we can pretty confidently run the drip for what is the standard time of 2 hours and be confident that our patients should remain hemostatic thereafter. The only other precaution that we should all know about is the fact that heparin also works on factor 10A. And so if you have given a patient Andexxa, heparin may not be effective to re-anticoagulate a patient in the immediate period after giving Andexxa. Now you can say, imagine, why would I ever give a patient heparin if I just reverse their anticoagulation? And there are a few circumstances, mostly surrounding cardiac surgery, where a patient will present with an acute need to go to the cath lab or to go to cardiac surgery and need to be anticoagulated shortly after reversal. And other anticoagulants would need to be used in the setting, such as argatroban or leparutin. Those are quite effective. And it's just heparin that has been affected by the Andexxa. So with all that being said, this is a very simple slide of what anticoagulation looks like today in the United States. It's really a very simple field. There are really 3 classes of anticoagulants, and in 2 of the classes, there's really only one main drug in the United States. In terms of vitamin K antagonists, it's really just warfarin, and there's 4-factor PCC for the reversal of warfarin. It works very, very well. There's a direct thrombin inhibitor. Right now, it's the Bigatran or Pradaxa, and it also has a specific reversal agent made specifically for that molecule. And then there are the direct thrombin inhibitors, what we've been talking about thus far, rivaroxaban and apixaban, or Xarelto and Eliquis. And for those drugs, for the 10A indirect inhibitors, we now have Andexxa. And so bringing back to the coagulation cascade, really we're going to focus on 10A, because 10A is what, again, allows for the creation of thrombin and fibrin and therefore your clot. And when you have a 10A inhibitor, it works directly on 10A, as you can imagine. And so to reverse those effects, you really want to do something that's going to remove those inhibitors and allow 10A to function again. And that's exactly how Andexxa works. Andexxa is a decoy molecule to factor 10. So what this looks like is this is an image of native factor 10. As you can see, it has an active site at the top where all of the inhibitors bind to stop factor 10 from working like normal. Andexxa looks exactly like native factor 10. It has the exact active site at the top there to bind the inhibitor. What it's missing is the prothrombinase complex that interacts with the clotting system. So Andexxa really just goes into the system and sops up all the circulating inhibitor and really does not otherwise interact with the clotting system. And so when the Andexxa binds with the circulating inhibitor, it frees up the patient's native factor 10 to go about and do its job like normal and allow the clotting system to work as it was designed to. So I think this is really, really novel because unlike many of the other things that we do to reverse anticoagulation, such as give people FFP or PCC or factor 7, all of these things are just adding extra clotting factor to the patient. They're pushing the system, whereas this really, in theory, is just sequestering the drug, the inhibitor, and not acting on the patient's clotting system at all. And I think that's a really neat approach. And that is why Andexxa is a specific reversal agent and not just a reversal agent by priming the clotting system, if you will. So let's talk a little bit about the data then, and I think this will also explain more about how this functions. I'm going to take you through two sets of studies. There were two phase 3 trials. One was done with apixaban and one was done with rivaroxaban. And then I'll take you through a phase 4 study that was done in actual bleeding patients. The phase 3 trials were actually done in healthy volunteers who again allowed themselves to be anticoagulated and then randomized to either receive placebo or Andexxa. And so you can see that these older healthy volunteers were randomized as I just described. And what we saw was the following. And this, I think, is one of the really important and helpful descriptive slides. There are two charts here. They look pretty much the same. You can just focus in on one of them if you want to focus in on the left one. What you see here is a red line and a blue line. The red line is the placebo group and the blue line is the Andexxa group. Both groups basically start at a fully anticoagulated level of anti-10A activity. So all of these healthy volunteers were fully anticoagulated at the start. Now, if you got placebo, you follow the red line, which is the natural degradation half-life of the drug. However, if you received Andexxa, you follow the blue line. And as I mentioned earlier, Andexxa is delivered as a bolus followed by a 2-hour infusion. And so what you see happening here on the blue line is that within 2 minutes of that bolus going in, there was 92% to 97% reduction in the anti-10A activity. And that reduction was sustained throughout the infusion period. And as you can see, when the infusion stopped, the half-life is very short. There was some increase in anti-10 activity, but reassuringly, when we look at this next slide, which is thrombin generation, what we see is that thrombin generation was normal even after the drip turned off. So again, there are two slides here, one at the top, one at the bottom. One is for apixaban, the other is for rivaroxaban. These slides are set up in the same way. What you can see is that patients were anticoagulated on the apixaban in the top graph. They all got to a therapeutic level of the apixaban, and their ability to generate thrombin was abnormally low or therapeutically low. The patients on the placebo group followed the red line, which again was the natural degradation of the drug, which meant that their ability to generate thrombin was delayed and took time to reestablish itself. However, if you received Andexxa, you follow the blue line, which shows an excellent ability to generate thrombin. And even after the Andexxa was turned off, you can see that that blue line stayed within the pre-anticoagulation mean after the Andexxa was off, meaning that the patient's ability to generate thrombin was normal throughout. And so this data, I think, was quite exciting. This is what led to the FDA approval, along with the data on the right side of your screen, which showed that none of these patients had thromboembolic events. They had no serious adverse reactions. And there were a handful of infusion reactions, things like itching and hives, things that I guess in general, if you're having a major life-threatening bleed, that you would not necessarily be too overly concerned about. And so what happened next after the drug was approved is that the sponsor did a phase 4 trial looking at outcomes in actual bleeding patients. Of course, anyone at this point could be given the drug. However, to be included in this data, you had to meet the inclusion and exclusion criteria. Again, the primary endpoints of this phase 4 trial were looking at anti-10 activity as well as clinical hemostatic efficacy. And of course, from the safety standpoint, The sponsor looked at thromboembolic events and mortality. And so again, in order to be included, you had to fit very strict inclusion criteria. You must have been on a known 10A inhibitor. You must have taken your last dose of that drug within 18 hours. You must have received the Andexxa per protocol, which was the bolus followed by a 2-hour infusion only. And you must have been followed over time for your outcomes. Further, there were some specific exclusion criteria so as not to muddy the waters. And these included the fact that patients could not have received any other reversal agents, no PCC, no factor VII, etc. There were no surgical patients included in this cohort because they did not want surgical outcomes to interfere with the data. Of course, anyone who had a recent thromboembolic event within the past 2 weeks was excluded, and anyone who basically had a life-ending bleed in terms of intracranial hemorrhage was also excluded. And this was meaning a massive intracranial hemorrhage. Excuse me. And so this is who the study population ended up being. About 2/3 of the patients who were included were intracranial hemorrhage. And as you can see, just over half of them were non-traumatic or medical bleeds, whereas just under half were traumatic bleeds. About 1/4 of the patients were GI bleeds, and then 10% were other types of bleeds throughout the body. The other interesting thing to note is that there was a safety population and an efficacy population. And the reason that those two numbers differed is because all of the patients were adjudicated for appropriateness to be included in the study, whether or not they got Andexxa. And so if you got Andexxa, you were included obviously in the safety population. But if you did not meet the strict inclusion and exclusion criteria, then there were some patients who got the drug who ultimately were not included in the efficacy population after adjudication. And so that's why the efficacy population was a little bit smaller. In a very interesting way, this data from actual bleeding patients showed very similar capabilities of reversing the 10A inhibition as to the phase 3 trials. There was 93% reversal or decrease of the anti-10A activity in both the apixaban and the rivaroxaban groups. And that was really exciting to see that the similar findings were found in the actual bleeding patients. There were very few or no adverse reactions. There was no immunogenicity. And in terms of mortality, the mortality rates overall were 15%, and for intracranial hemorrhage specifically was 16%. Now, I will hearken you back to the beginning of this talk where I mentioned that the mortality rates in the Aristotle and Rocket IAF trials, which were the trials that brought the 10A inhibitors to market, that the mortality for an intracranial hemorrhage was nearly 50%. And so in this study, it was 16. And what that tells me is that these patients are really no longer acting like an anticoagulated patient. They're acting like a more normal patient who's presenting with an intracranial hemorrhage for one reason or another. And so I think that's really profound to see such an improvement in mortality. Now, in terms of thromboembolic events, there were a significant number of thromboembolic events within those first 30 days. However, interestingly, if patients were restarted on anticoagulation within the first 30 days, the risk of a thromboembolic event could be mitigated to a significant degree, and that was 8% here. And certainly, if patients made it back to oral anticoagulation, there were no patients who had a thromboembolic event in that cohort. So I will say, if you think about 30 days, that's actually a really long time to be able to restart anticoagulation. And I will say that I've seen the data that shows that it's a pretty linear risk over time over those 30 days. And so if I look at my own practice where we will re-anticoagulate someone after a bleed, it's usually 1 or 2 weeks later. Even if I have to get a cardiologist and a neurosurgeon in a room together, usually they can come to the conclusion that we would re-anticoagulate within 1 or 2 weeks. And so you can see that thromboembolic risk can really be mitigated if we think about the patient's underlying need of anticoagulation, what their risk is, and then decide to do it in a controlled setting. And that's a big change because not that many years ago, I would have sent someone who was on Coumadin home on nothing and said, follow up with your primary doctor and figure out when to restart it. But now I actively think about what their underlying disease processes are, what that indication for anticoagulation was, and decide when to use it. And so, of course, with this data, a host of organizations and societies have endorsed its use and have recommended it as a tier 1 recommendation or first line agent, et cetera, et cetera. I won't necessarily drag you through the comments that have been made. This is certainly available and out there. But I will also note that the Joint Commission themselves have recognized the fact that 10A inhibitors have been associated with significant harm to patients. And actually in a publication in their Sentinel Event Alert, which is their a publication, that they actually mentioned that hospitals should look to have specific reversal agents for specific drugs such as 10A inhibitors. And so even the Joint Commission is starting to say that if there are specific reversal agents, that we should at least have them available. They do not go into when to use them. I'm happy to talk about when we use them and when we don't use them. But the availability of them, I think, is something that we all should try to consider in our practices. Really briefly, I'm just going to go over some dosing and administration. Andexxa does come as single-use vials. We talked about the fact that it's a bolus followed by a 2-hour infusion. There are 2 dosing levels for Andexxa. There's a low dose and a high dose. Most patients are going to require the low dose. In fact, in the phase 4 trial, 84% of patients received the low dose. In order to need the high dose, you actually must have been on a high dose 10A inhibitor, and you must have received your last dose within 8 hours. If you don't meet both those criteria, you just need the low dose for reversal. And that's 5 vials that needs to be reconstituted. The number of vials is important more so for pharmacists because it takes them a little bit of time to prepare this. And at our institution, this can take about 15 or 20 minutes to prepare the drug into an IV infusion form. Once you reconstitute it, it does have a relatively short half-life. And so if you are going to reconstitute it, you should absolutely plan on giving it. We do not reconstitute drug unless we absolutely plan on giving it to a patient because it's only good for 8 hours at room temperature and 24 hours refrigerated. And then finally, the concept of reanticoagulating patients when it's appropriate. Again, I think we've talked about this earlier to an appropriate enough degree about reanticoagulating our patients when we feel it's clinically indicated. And so this is really the summary slide here. It basically says that Andexxa is currently the first and still only reversal agent for apixaban and rivaroxaban for patients having a major life-threatening bleed. I showed you data that says that reversal will happen within 2 minutes of that bolus going in and will stay suppressed for the duration of that infusion. To 93% efficacy. The overall mortality in this phase 4 trial is 15%. And again, there is a risk of thromboembolic events, but that can significantly be mitigated if reanticoagulation is implemented within those first 30 days. And so with that, again, I want to thank both the Society for the privilege of speaking before you and to Alexion for providing the ability for me to speak on their behalf. And with that, I am happy to answer questions. I will exit my slides so that maybe you can see them.
Good afternoon. Can you hear me?
Yes.
Hey, thank you. That was really a very cogent summary of this problem and this drug. Thank you. But the elephant in the room is the exquisite cost of this medication. Is there? Can you address that, and can you talk about any prospects for a more affordable version, or and then in our hospital we can't prescribe this without a gatekeeper, and I wonder if you can talk about how, if that is a common practice and whether that's effective in getting the drug delivered to the right people? Thank you.
Absolutely. Yep, great questions. I will tell you a little bit about our experience. We have a pseudo gatekeeper in that when we first put this drug on formulary, created a clinical practice guideline or guideline for use throughout our health system. And the chair of the anticoagulation subcommittee of pharmacy and therapeutics went around to all of the stakeholders and introduced them to that guideline, so that the moment the drug went on formulary, everyone knew the very appropriate indications for use and instructions for use. I will say that those stakeholders included trauma, it included emergency medicine, it included neurosurgery and neurocritical care, and of course, hematology. The guidelines at our institution were things like you have to use it per protocol, just in the way in which the studies did it, with an infusion followed by, with a bolus followed by 2-hour infusion, that we had to know very strictly that the patient was on a 10A inhibitor and exactly when their last dose was, and that we thought that this was a very reasonable candidate, that the patient didn't just have a ditzel little bleed, or that the patient wasn't already too far gone in a non-survival state anyway. And so with that understanding and that education that we put forth in our guideline from the onset, what we found was that we use this drug only about twice a month. And that's across the house. That's including trauma, including stroke. We're a level 1 trauma center. We're a comprehensive stroke center. That's all of the GI bleeding. That's everyone. And so, whether we're too stringent, it's hard to say. I will say that our pharmacy looks at every time we use the drug to decide if they felt it was appropriate. And so far, it looks like most of the uses have been very appropriate. And so this is not a drug that we're using 5 times a day and going to blow pharmacy's budget. And really, I think what our guideline has created for us is that we're identifying the patients where this is going to be maximally beneficial and where we are going to change outcome. And I will say that, the handful of patients that I've had the chance to use it on, I really have felt it has changed their outcome. As a trauma surgeon in trauma performance improvement, we use the term unexpected survivors. And I've absolutely seen unexpected survivors who've come in with a big bleed on a 10A inhibitor. And with reversal, we were able to kind of get them through with a functional outcome. So I think we are very careful with who we give it to, but in that setting, if you can change outcome, then I think you have a reasonable rationale for its use, recognizing that it is an expensive drug. The other thing to say, and I think that the company reps can tell you more about this, but CMS has recognized the fact that this drug is expensive, and they have mechanisms for reimbursement. They have, because the DRGs have not caught up to the existence of this drug, institutions can absolutely apply and get, I think, up to 65% of the cost of the drug reimbursed per usage. And in fact, if the drug is given at a feeder hospital, a hospital that gives it, quote unquote, as an outpatient, gives it in the ED and then ships that patient elsewhere, CMS reimburses that drug at 104%. They added that 4% to encourage the small hospitals to keep it on formulary so that they can actually give it an effective outcome sooner than waiting for those patients to get to the tertiary and quaternary care centers. So hopefully that's a little bit of guidance. It's not kind of where you were heading in terms of, a cheaper option. But I think with good reimbursement from CMS and appropriate use, we can select the few patients that I think will maximally benefit. And I think that there is maybe a place for it in that setting.
Any other questions? All right, hearing none, I'd like to thank Dr. Martin as well as Alexion for their support of this luncheon as well as for the educational content and bringing us up to speed on this important pharmaceutical intervention. Thank you so much.